over to Isaac, who can share his screen and go through his presentation.
Thank you so much. Let me just share my screen. Okay, just confirm if you're able to see my screen.
Yes, we can see your screen, Isaac. Thank you.
Okay, thank you so much. So once again, thank you for the introduction, but let me also just run through once again. So my name is Isaac Nkandu Mwakilima, and I am Programs Director for Latu Human Rights Foundation in Zambia. And before I even run through the presentation, maybe just allow me to say thank you to ARBAC for the support that has been rendered to Latu Human Rights Foundation. And this support has enabled us to get to know and understand some critical factors that are affecting how STI treatment as well as management overall is performing in our country. And yeah, maybe with that note, I can start the presentation by going to the first slide. So that's the presentation outline, and I'm going to run you down from the background all the way to the conclusion. Yeah, so as a background, Zambia faces significant challenges related to STI prevention and control, especially among key populations whose access to the services remain concerning. And these challenges are due to obvious reasons where Zambia hasn't yet legalized or begun to acknowledge the human rights of the key populations in Zambia. And this has caused an impediment of the populations to access services in healthcare facilities. Latu Human Rights Foundation is championing for equitable access to HIV and sexual reproductive and rights for marginalized population, including the MSM, the people who inject drugs, as well as the sex workers. So the project was founded by ABAC and implemented in Kabwe and Dola districts and collected data on STI services in 8 public clinics in Zambia, a country which is in Southern Africa. And just to run through the project objectives, the overall objective is to conduct a landscape analysis for STI advocacy, needs and capacity in current and future prevention advocacy programs. And our specific objectives were to create an understanding on the community needs and perceptions around STI advocacy in Lusaka, Kawe, and Dola districts of Zambia. And we also intended to identify the gaps in knowledge, attitudes, and practices related to STI prevention and advocacy. Thirdly, to assess opportunities related to local STI vaccine and diagnostic research and development in Kabwe and Dola districts. We also intended to document insights on ongoing projects, challenges, and potential collaborations among the local research institutions, pharmaceutical companies, and healthcare professionals. And lastly, we wanted to identify the best practices and innovative approaches in STI prevention advocacy. So just to give an overall program update, so far we have developed the project methodology. There was the development of data collection tools, which was a very comprehensive process. We had to also engage other people who are very well vested in STI management in just coming up with data tools that would collect the data that was pertinent for this project. And we also had to circulate self-administering online surveys to the key populations. We also administered to the healthcare providers so that we get a comprehensive feedback. We also looked at regional stakeholder mapping, which is something that was done, and we granted access to national supply chain online system. So this was granted to us just so that we can be able to look at what's happening in the supply chain for this. Confirm if you can hear me. Sorry, I thought I lost internet.
We can hear you.
Okay, all right, thank you so much. So on the project successes, we were able to reach out to the KPCSOs in Zambia through our network so that we can just have their feedback as well in terms of what they perceive is happening in the country with regards to STI screening and management. We engaged provincial health leadership to allow for facility level data collection. So we were also able to conduct focus group discussions in 3 districts, which were Ndola, Lusaka, as well as Kabwe. So on the methodology, this was a mixed methods approach. So we were looking at the collection of quantitative as well as qualitative data. And on quantitative data, the indicators were collected through the online administered client level questionnaires, and the data were collected using Google Forms and stored on a secure server. On the qualitative aspect, the interviews were conducted at health facilities, and each data collection team had 1 facilitator and 1 transcriber. So this was just showing the process of what happened. So we are looking at the distribution of respondents by age and gender. So these are the respondents to the questionnaires that were administered. So we can see that we had the highest number of respondents coming from the age of 25 to 34, and most of them being female. And the least was from the age of 45 to 54, and most of them were actually females with 9. So we had a total of 96 respondents on the project so far. And this table is just showing us the distribution of respondents by population type. So we are looking at the key populations where 63% of the respondents were female sex workers. We had 31% of the respondents coming from the MSM, and 6% were transgenders. So on the analysis, there was descriptive analysis and cross-tabulation tables, which were created for key quantitative indicators. Qualitative transcripts were reviewed by members of the research team for thematic analysis. So the themes were derived from the objectives, and the qualitative data were intended to answer. So just a snapshot in terms of awareness of the advocacy efforts for key populations, where N is equal to the 96, which are the number of respondents that we had overall. So we can see that 42%, which was the 42.9, which was the larger proportion of the respondents, were very aware of the STI advocacy efforts. And we had another 42.9% who were somewhat aware, not very aware, but then they had some little bit of information when it came to advocacy efforts. Then we had 14.3% of the respondents not being aware of the advocacy efforts so far. Then factors influencing STI testing. So we had a large proportion of 85.7% of people who were the respondents who had knowledge about the importance of testing. Then the other 14.3% had access to LGBTQI plus friendly healthcare services. Maybe just to run through this slide again. So I'm talking about the factors influencing STI testing. So the biggest chunk of people said the knowledge about the importance of testing was a factor that influenced STI testing, and 14.3 said access to the LGBTQI plus friendly healthcare services also influenced the uptake of STI testing. So in terms of STI diagnosis, as you can see from the table, from the bar charts, we had urinary tract infections coming in the highest at 34. So the respondents of that were amounting to 34 did register that they had urinary tract infections, followed by syphilis at 22 of the respondents. Gonorrhea, we had 11, and herpes simplex virus, we had 4. So in total, we had 71 who were able to attest to STI diagnosis. Then the challenges that we had on the project were that key populations faced security risks, hence hesitation in responding to surveys. So we had this challenge throughout the 3 districts that we administered the questionnaire, where the key populations were a bit hesitant because they thought maybe the information could be leaked, but we did ensure to just remind them that this was information that wasn't going to be shared to the public and their identities were going to be hidden. Then we also had lack of STI screening kits and drugs in healthcare facilities. So this is one of the biggest challenges that was brought out by the key populations themselves, as well as the service providers, who attested that screening kits and drugs were very scarce in these healthcare facilities, hence posing a huge challenge to access. And on the way forward, the first one, which is engaging key populations through their networks with civil society organizations, this reduces on the risk that is associated with being a respondent on such a project. And it also helps to clear out some of the misnomers that the key populations and hence the respondents would have being part of such a project. Then we also recommended working with the Ministry of Health in securing STI screening and test kits in healthcare facilities, in that this was one of the biggest challenges that was highlighted from this survey. So we thought working with the Ministry of Health would help to impede this challenge going forward. Conclusion, there is vast awareness of STI knowledge in the study community. Lack of education in health facilities prevent key populations from seeking services early. Key populations, civil society organizations play a key role in informing or information dissemination about STI to their community members. Stigma and lack of KP awareness among healthcare workers hinders key populations from accessing services. And lastly, there is need to invest more in STI commodities at public health facilities. I think this is where the presentation ends, and I'll throw it back to you.
Thank you so much, Isaac. That was a really great presentation. And I see that Henry is also in the chat adding additional comments. A reminder to everyone that we are just going to go through all of our presentations and have a short Q&A session at the end. So if you could add any questions to the Q&A in Zoom, that would be greatly appreciated. And with that, we are going to transition over to Acts 101, where Bridget will be leading a presentation with her colleagues Arafat and Shakira.
Thank you, Alison. Alison, are you going to share the presentation?
I can. I
Okay.
thought you were, but I can't. No, I absolutely can.
All right, thank you, please.
There you go.
Thank you so much. Good day, everyone. My name is Bridget. Thank you so much, Alison, again. So this landscaping was done by 3 people under Acts 101, and they will be joining me to make the presentation with me. Next slide, Alison. So it of course goes without saying that we can't miss the fact that STIs have made it back onto our radar, and this is not new to us because STIs were a big shot until the focus shifted majorly to HIV, given of course the severity of its effects to global health. But here we are again bringing these discussions back to focus, and as you see on this slide, the alarming numbers of you see 1 million STIs acquired every day, worldwide. So given this data, but also given the big focus of HIV, as I mentioned earlier, Uganda's strategy for STI management aligns with HIV. I mean, they go hand in hand. And this focuses majorly on STI primary prevention through VMMC, voluntary medical male circumcision, screening, diagnosis and treatment of STIs. We have social behavior change communication and vaccination of a few STIs, and that's just hepatitis B and HPV. Next slide, Alison. So, this is an interesting slide for us. It was an interesting data set, given that Act 101's focus on adolescents and young people is really key to us. But this slide looks at data that really highlights the trends in STIs among adolescent girls and young women from 3 demographic and health surveys that were taken between 2006 to 2016. In Uganda. And as you can see, the prevalence is higher among the 20 to 24-year-olds, even when data from Uganda suggests, we have a lot of data that suggests that our sexual debuts are as early as 16 for females and 15 for males. But if you look at this, the prevalence for STIs is really centered, is majorly in the 20 to 24s, or is more in the 20 to 24-year-olds. This data also highlights we're seeing consistency in condom use and some gaps in STI information. And of course, our landscaping survey also really highlighted these gaps as we see in this data. And this is one of the highlights from our desktop review. So I want to call Arafat to come in to take us through the survey methodology and data analysis. Arafat?
Thank you, Bridget, and greetings from Uganda. Very quickly taking you through the methodology. So this landscape survey employed 2 methodologies.
Sorry,
one was
Arafat.
the...
Alison, next slide, please. Oh, okay.
Oh, yeah. Sorry about that. Yeah, so we employed the double layer process here, the Mackenzie 7S framework, alongside this the SWOT analysis. When you talk about the 7S framework, we look at strategies, structure, systems, staffing, skills, styles, and then shared values. So we applied the SWOT analysis to help us dissect through all those 7 S's to ensure that we get to the core of the problem in terms of opportunities and the gaps in that regard. When we move to the next slide, we can see that the SWOT analysis and the Mackenzie 7S framework was applied for the key informant interviews, the data review for the tools, and then as well as the focus group discussions in here. So this slide is basically talking about the literature review that we did, whereby we looked at the global and national level strategies, guidelines, reports, and other publications that are available. We also looked at data from that was available in terms of DHS2 and other reports that have been published. When we go to the next slide, we'll talk about the data collection. And I briefly said that we did data collection from focus group discussions and the key informants. Very brief that the focus group discussions looked at the MSM, adolescent girls and young women, adolescent boys and young men, civil society organizations, research institutions, health workers, teachers, students and student leaders, while key informants focused on the Ministry of Health, STI control program, civil society organizations, development partners like USAID, UNFPA, and very many others. We also decided to co-opt village health team members and then also laboratory technicians because they mostly interact with STI programs either at community or at health facility level. The next slide talks about the data analysis. And like I've said, we employed the double layered analysis methodology here, the Mackenzie 7S framework alongside the SWOT analysis. So we dissected all these 5 key components: the STI advocacy, STI funding, diagnostic tools, prevention, vaccines, and each of them we looked at what are the strategies. For example, STI advocacy, what are the strategies in existence? What are the structures that are available, the systems, the staffing? Here we're looking at institutions that are doing STI-related advocacy. What are their staffing and skills? What are the styles in terms of governance, leadership, and management? And from the findings, we are going to look at really what came out in terms of all these 7 S's in there. And just to be guided, Bridget, Shakira will be taking us through the findings very quickly. And
Yes.
for me, that was a bit about the methodology. Thank you.
Thank you. Shakira, next, you're up with the findings.
Hi, everyone. Yes, thank you, Bridget and Arafat. So under the STI advocacy, under opportunities, we found that there are existing policies and guidelines, that is the adolescent health policy communication strategies developed by the Ministry of Health for STI programming and prevention. There is also civil society-based structures to lead advocacy specific to groups like the AGYW Forum, the Civil Society Advocacy Coalition for Integration of SRHR, HIV, GBV, and the ADH, that is the Adolescent Health Forum. So we also saw that UNFPA and other partners through non-government organizations support youth-friendly corners like MildMaid, Infectious Disease Institute, Baylor, Uganda, AIC, and public health facilities. These are just a snippet of what we found. Because of time, we couldn't put everything. And under gaps, still under STI advocacy, there's limited funding specific to advocacy efforts for STIs. The current advocacy efforts are not extensive and not sustainable. Gaps in information, access, that is language target on STIs to support advocacy. And also STI advocacy is not strongly incorporated within organizational areas of focus and strategies. Next slide, please. Still under opportunities, there is availability of funds through the HIV program, the HIV control program. There is STI programs integrated within most HIV clinics and at the health facilities. STI commodities are budgeted for in the national annual procurement profile for key commodities. And still under gaps, we have funding is limited to STI treatment, and few resources go to prevention. And these are mostly funded by PEPFAR and USAID. So Uganda lacks an STI funding strategy. Available funding excludes grassroots organizations and community-based organizations, which ideally reach the communities more. And also mismanagement of funds. We know that corruption among our governments and non-government partners is an issue. Next slide, please. Next slide, I just mentioned this under STI funding. Sorry, the other one was a repeated slide, yeah. So under STI diagnostic tools, the opportunities we have is that in 2016, 16, Uganda clinical guidelines adopted from the WHO guidelines provide the criteria and algorithm for diagnosis of STI clinically and through lab tests. The guidelines also go ahead to provide treatment and management and prevention options. Another opportunity is research has supported availability of diagnostic tools and treatment for STIs, and also partners with the private sector, partnership with the private sector to provide STI commodities to public at a subsidized price, and also availability of rapid diagnostic tests make work efficient during diagnosis. So under the diagnostic tools, the gaps that we have is integration of STI diagnosis services into off-site interventions like integrated outreaches and immunization programs. There's a high cost of some of the STI diagnostic tools, and then constant stock out of essential STI diagnostics and treatment tools in most public health facilities, which limits access to the diagnostic services. Next slide, please. So under the STI vaccines, the opportunities that we saw under this was they are trained health workers by MOH that is Ministry of Health in STI management and vaccination, Uganda National Extended Program of Immunization under the Ministry of Health. There is revised HPV delivery strategy in place to guide increased HPV vaccination coverage, and then MOH leads integrated and health days in the months of April and October every year. Under the STI vaccines, the gaps that we saw is only 2 STI, that is HPV and hepatitis B, have vaccines available in public and private health facilities. Other STIs like syphilis, gonorrhea, chlamydia have no vaccines yet. So there are many myths and misconceptions driven by culture and social norms, which limit uptake of the vaccines. And then poor cold chain and limited storage facilities coupled with limited access to power supply in limited resource settings impacts access to these vaccines. Next slide, please. Please allow me hand it back to Bridget to help us wrap it up. Thank you, guys.
So thank you so much, Shakira. So I will quickly take us through our recommendations, and this will just wrap this up quickly. And as Shakira mentioned, this was a much bigger report, but we needed to compress this to fit into the time that Alison gave us. But we did segment the recommendations into 3 types of stakeholders, and we were targeting the Ministry of Health. We targeted civil society and communities, and then development partners where funders fall in there, and other partners in the country. And of course, this was side by side with the thematic areas that were mentioned by Arafat in the analysis, and that's funding, advocacy, diagnostic tools, prevention, and vaccines. So we suggested a focus on a targeted fund for STIs, essential drugs. And this is, of course, towards uninterrupted access to commodities. We looked at systems to capture disaggregated data in terms of prevalence by age, sex, by population, name it. But also looking at highlighting commodity stocks and other key indicators. And this is basically to inform prioritization, but also to, how can we better advocate for STI programming. We noted that prioritizing STI research as part of the national research agenda, and also strengthening cold chains for vaccines is quite a pertinent issue in moving forward when we talk about STI programming. Then in terms of civil society and communities, we know that they play a big role. And here we really highlighted, the need to strengthen advocacy efforts towards increased financing, towards, advocacy towards local vaccine research, developing an STI advocacy agenda. As Shakira mentioned, that's a big gap. But also in terms of community-led monitoring for STI country programs, CLM for policy, for research, basically something like a tracker and to document gaps and best practices that can be shared to different partners in the country. There is also need to have increased financial commitments and allocations from donors, from development partners, even governments, for STI programs, for research. And here in research, we look at, prevention, we look at things like vaccines, how can we have like vaccine development, locally in the country. Even advocacy itself actually needs financing. So we look at like STI funding really, targeting development and access, and of course, looking at revision of diagnostics to address the needs of communities. Next slide. Okay, so in conclusion, and we call this the upshot because it really wraps up everything that we really were looking at. As I said, it was really a mouthful. It was wordy. We really found out too much, but really in a nutshell, as a country, the STI response is still lacking, and this is ultimately evidenced by what we have seen as an unprioritized focus on STIs, and the inadequate funding that we have in the country. And we'll see even where integration of STIs into HIV programming is happening, STI programming is still overshadowed by, the bigger HIV programs that we have within the country. But also we see our findings from this landscape survey presented here today, highlighting the need for a refocus and, to target more STI programs in the country to address the structure, to address, systems, research, and development gaps that exist. And I'm sure Shakira has done a very good job to really highlight these gaps. Next slide. Thank you very much. Back to you, Alison.
Thank you so much, Bridget and your team, for this amazing presentation. Our final presentation this morning will be from Journeys, and we will have Dingon presenting. Dingon, do you need me to share slides for you? Dingon, we can't hear you if you're speaking. Dingon, are you able to join us? We still can't hear you. While Dingon is working on audio, we will actually take a few questions. So I am looking at some of the Q&A. So Bridget, this is specifically for Acts 101, and someone has mentioned how they have not seen a mention of herpes in the report. And so are there any information or thoughts on this and how to include herpes within some of this work?
Hi, Alison. So as I mentioned, we really do have an extensive report, like a bigger report, and we could not put everything in here, but herpes is also like a focus in Uganda in terms of diagnostics and treatment. We can, Alison, I don't know what your plan is in terms of sharing the bigger report, but that is something we looked at as well.
And so for additional information, all of our organizations were funded to really examine 7 different pathogens, including herpes. And as Bridget and a lot of the other teams have mentioned, they do have these really extensive reports and a lot of great information. And we are working with each of them to really understand how to get this information out to the public, whether that is through fact sheets or manuscripts or publishing the reports as is on our website. And so we will definitely keep everyone updated with the publication of all of this data, and hopefully we'll know more in a few weeks. We have another question. I think, Isaac, this might be for your team. So someone has mentioned that, as you know, urinary tract infections are not an STI. How is this managed among participants who mentioned a UTI?
Thank you so much for the question. So in terms of UTI, this was also just something that we used as a proxy in our project, just to ensure that we are assessing the knowledge gaps that we are having in the community, because as you might know, most of the community members are likely to mistake the UTIs for STIs. So we just thought of incorporating them into the projects just to see how many people would actually have an understanding of the differences between the two. Yeah, otherwise that's a good question, and we've taken note. Yeah.
That's really helpful background information, Isaac. And it looks like, Dingon, you've been able
Hello.
to connect.
Hello.
Would you like me to share your slides?
Please proceed. Can you hear me?
Yes, we can hear you. Your volume
Okay.
is a little low, but we can hear you.
Okay.
Okay, I am sharing your slides.
Okay. Thank you so much for giving me the platform, and other colleagues who are, I think, unfortunately, they're on the road, so they're not able to join me. But I should be able to take you through the presentation. So this work was done by my colleague Sostin. You can see there, and also myself, as well as Christopher. Next. Okay, so Journalists Association Against AIDS is a local media NGO based here in Malawi. We do advocacy work around reproductive health. We do HIV, universal health coverage, climate and sustainable development, as well as COVID-19. And
Sorry, Dingani.
hello?
I don't know if everyone else can hear you, but I'm struggling from my end.
Can't you hear me?
Much better now.
Can you hear me now?
Much better. Thank you.
Okay. Right. Okay, so hello everyone. So Journalists, we are doing work around HIV, reproductive health. We do universal coverage, climate change, sustainable development, as well as pandemic prevention and preparedness. So the STI landscape analysis was done here in Malawi at national level. So we looked at different policy frameworks around STIs. Next. I don't need to dwell much on that to say that Journalists do adjustment grant EVAC. We did an analysis. We used a desk review. Ours is a bit different from others because we're not much to focus on discussions. What we did, we just looked at the policy, just did a scan to see what is happening on the ground around the STI. So we looked at the health sector strategic plan for Malawi for 2022, 2030, the current one. We also looked at the World Health Organization global strategy on STIs, as well as other sexual reproductive health policies. So this work aligns to our strategic plan for 2022 to 2025. Next. So the goal for landscape analysis is to contribute towards enhancing evidence, the use of evidence to inform policy making in the prevention of STIs, and accelerate diagnostic research and development in relation to vaccines and other imaging new technologies. Next. Yeah, so we do, as I said, we used basically secondary data analysis. Who can't hear me? I'm not audible enough?
We can hear you.
Okay, but someone says I'm not audible. I don't know why. Okay, so let me continue to say that the policy landscape analysis. Now we looked at the major SR, HR, and HIV policies. We looked at the health sector strategic plan 2022 to 2030, the national SR, HR policy 2017-2022. We also looked at the HIV strategic plan for 2020 to 2025, as well as the STI management guidelines for 2017, as well as the new national hepatitis management guidelines, which have just been developed this year in June. Next. Yeah, so what did we find out from the landscape analysis? Number one, for the Malawian perspective, we saw that much effort has been concentrated into prevention and control of HIV, while there's been a neglect around STIs that also facilitate transmission of HIV. So one of the key challenges in STI prevention in Malawi, basically, STI treatment coverage in Malawi is very, very low, around 41%. And I should also explain to you, before I go any further, to say that in Malawi, data around STI is very, very scanty. You won't find any data. It's very, very difficult to find the data, which also shows you how we have been neglecting STIs for a long time. So apart from the low STI coverage in Malawi, around 41%, we also find that there's poor quality STI services. There are many reasons why there's poor quality, long distances, long waiting times in public health facilities. Also, there's low HIV testing rates in STI clinics, around 49%. This is Ministry of Health data. And also, the significant number of STI patients access private sector facilities to access treatment, unlike in public facilities, because of different reasons. And also, the adherence to the national treatment guidelines for STIs is also very, very questionable in many, many cases. And also, reporting to the national STI program is also a very, very huge challenge now, looking at the data from the Ministry of Health. Go next. So around 2015 to 2016, there was what we call the MFIA. It's the Malawi Prevalence HIV Impact Assessment. Yeah, it's a new study which has been happening in the past 6 or 7 years or so. So it shows that there's significant underdiagnosis of STIs in Malawi among HIV positive males, especially within the age bracket of 15 to 64. So you see that FIA study showed that 16% reported to have had a genital ulcer, 5% have had abnormal discharge from the penis, but only 6% have been diagnosed with an STI in the 12 months preceding the survey. So you can see that diagnosis for STIs in Malawi is quite a very huge challenge. It's quite very, very low. And also among HIV positive females 15 to 64, 12% reported to have had a genital ulcer, 11 to have had an abnormal discharge from the vagina, but only 7% had been diagnosed with an STI in the last 12 months preceding the survey. So you can see 6% males versus 7% females, very low. So in 2014, there was also a youth-friendly health services evaluation report for 2014, which found that young people's access to sexual reproductive health services is enhanced by proximity and awareness to some of the health facilities, which means if you have got very long distances to facilities, most young people likely will not going to access these services. So proximity is very critical. Next. So program data has shown that has shown an increasing demand for STI services, very huge demand. So in 2018, Malawi recorded around 395,583 cases from 267,862 in 2016. So you can see that between 2016 and 2018, there's a 48% increase in this case, showing that in Malawi, STIs are really growing if you look at the data. And also the rate of HIV status ascertainment among STI clients increased from 69% in 2016 to approximately 87% in 2018. So that represents around 18% increase and nearly 90% target. So the HIV yield among STI clients halved between 2016, that's around 66%, and 2018, around 4%. And coverage of syphilis screening among antenatal women increased from 2016 to 2017. So you can see 75% versus 84%. Okay, let's go next quickly, in the interest of time. Next. Yeah, so I can also explain here to say that STI programming in Malawi has never been well integrated in many HIV services. And also, you see the separate vertical health programs have resulted in lost opportunities, offering clients multiple services at a single visit. That's the biggest challenge now. And also, STI programs have not been given a high priority, and efforts to prevent HIV transmission were largely managed through programs that were funded, implemented, and evaluated independently of other STI control efforts. So you see the working in silos there, the mismatch. So that's another challenge Malawi is facing. Let's go next. Next, please. We also wanted to find out as a country, and just go back a little bit, just go back. Yes. So the analysis scanned for specific STI policies and found only one 2017 STI management guidelines that guide health workers to treat STIs in Malawi. And basically in Malawi, we are using the syndromic approach. I think you know what the syndromic approach is all about, using the symptoms. So right now, Malawi has spent like 6 years without new STI management guidelines. So you can see the gap there. And also, as I have said earlier on, there's no specific STI policy apart from guidelines, which have not been reviewed for 6 years. If you see the SRHR policy for 2017-2022 also mentions STIs with very scanty information, very scanty. I can share with you the documents so that you can see for yourselves. It's very scanty. No inclusion of HPV, no inclusion of herpes simplex virus. It also mentions nothing about diagnostics. So you see the challenge. Of course, we have the new hepatitis B and C management guidelines for June 2023, which I have seen. Next. Yeah, so the analysis found that people have to travel long distances in order to access health services. And also there's a very huge dissatisfaction with the absence of SRH services offered closer to people. In Malawi, access to health services is through the public, but then you find that public health facilities are located at least within a distance of 1.5 to 5 kilometers. And then the health services sought include general medical conditions, STI, HIV testing and counseling, ARVs, cervical cancer screening, family planning, antenatal, and other services. So go quickly, next. So the majority of STIs have no symptoms or have only mild symptoms. Data from Malawi shows that algorithms for the diagnosis and treatment can be effective. Urethral discharge and genital ulcer disease in men had cure rates of around 87%, 99%, and 60%, versus 98% respectively. So young people in Malawi basically don't prefer public health facilities. They would rather go to private healthcare services, private facilities to access STI treatment, just because if they go to the government facilities, the services are quite very slow. They wait too long in the queues. So many young people like going to private facilities. It's also the same with even adults, not only young people. Next. So what's our conclusion from this quick landscape analysis? We're finding out that ending STIs in Malawi, which is also an epidemic, of course, as a public health concern by 2030, this is going to require massive reduction in new infections. Also, we need to vastly scale up primary prevention and increase access to screening for STIs, increase awareness of the public, health impact of STIs, and also secure adequate funding because funding is lacking. For now, more research and development is critical in tackling STIs in Malawi. And also, there's a need to develop new STI-specific policies effectively to be implemented. Next. Malawi has been using the syndromic approach for STIs, where modern and accurate diagnostics that diagnose STIs in one group are not feasible in the country due to limited resources. And also, if the country is to re-energize STI work, there's a need for an investment case for Malawi to bolster investments for STIs, human resources for health, financing, diagnostics, vaccines, research, and also public awareness, and also policy coherence. So STIs basically, they need a lot of attention from policy and decision makers, which is hugely lacking at the moment. Next. Yeah. So Zikomo, thank you. Let me stop there. That's our landscape analysis for Malawi. Quite very short and just straightforward. Thank you so much.
Thank you so much, Dingon. That was a really great presentation. And so we have just a few more minutes left for some additional questions. And so we do have a question in the Q&A that says, I think I missed it, but in these countries, is there a national STI strategy? So I think every team can really speak to or answer this question for your specific country and understanding what STI strategies are available and what might be missing. And Bridget, I see your face first, so you can go first in answering this.
Alison, I'm sorry, come again.
So are there a national STI strategy within your country to better address the needs for STIs prevention services?
All right, so as we mentioned earlier, our STI response is really solely under HIV. So everything STI, really, we use the HIV response, the strategy, and the guidelines that we have for HIV. And that is part of our recommendations. If we can have an STI strategy as a country, that would be good to address the gaps that we have in the STI programming. Thank you.
And so Dingon, same question. I know you mentioned it just now in your presentation, but what are your thoughts on a national STI strategy in Malawi?
No, Malawi doesn't have an STI strategy at this point in time. We don't have.
And Isaac, same question for you, a national STI strategy.
Hi, Alison. So in Zambia, we have the hepatitis B strategy, and we have the NACIF. So the NACIF also incorporates STIs separate from HIV. However, the NACIF hasn't yet been fully adopted in terms of its provisions for STIs, because it only talks about them in a very narrow and, narrow perspective, where it doesn't really talk about the intricate management of STIs, but then just recognizes that STIs are in the country and they need to be sorted. But we don't really have like a comprehensive strategy that talks about all STIs only the hepatitis B strategy. Thank you.
And there was another question. And so we have one attendee who wants to know, did anything related to partner notification or index testing for STIs come up in your projects? And so Dingan, we'll start with you. So for Malawi, was there anything about partner notification for STIs?
No, no. I never found that. No, unfortunately, we didn't.
And then what about for you, Isaac?
Hi, can you hear me? Okay, all right. So for the case of Zambia, we have one facility that does partner notification for STIs. That's the University Teaching Hospital. I think they are the only facility, and they are located in Lusaka, which is the capital of Zambia. But then this is yet to be broadened to other places in the country where partner notification and index testing can be done. However, this has been a huge debate, so to say, in terms of index testing for STIs, where the key populations themselves, first of all, have been trying to fight against the index testing in HIV. Then the incorporation of STIs also has raised some bit of questions like, why should we be called? These are just STIs. If I have symptoms, I can easily go to the facility. It's not like I'll die from them. We should not be called for index testing. So it's still something that is happening on a very small scale, only one facility, the whole country. But then, yeah, that's the current situation.
Thank you, Isaac. And then Bridget, for you as well, anything about partner notification or index testing?
So we do have assisted partner notifications within our HIV programming, and that's solely under the oral prep program in the country. As we know, like STIs are highly associated with the use of oral prep here, and that's what actually sparked the focus for STIs. It was within the oral prep program. So we do have that, but as Dingan has mentioned, there's really been a big fight about index testing and assisted partner notifications in terms of STIs. And of course, there've been issues, and there's different data to show really that the gaps when it comes to partner notification and STIs. But as I said, this is all not solely under for it's not solely for STIs. This is under the HIV programming. So I cannot really say that it is really distinctive for we do like assisted partner notifications for STIs. It's really under HIV. Again, that's what brings it out to say that we really need a different whole program for STI. So these things can be tracked and can be linked to STI programming rather than HIV. Thank you.
Thank you so much. And thank you to all of our presenters today for these phenomenal presentations. I think that we are all incredibly grateful for the work that you've done and have just learned so much. With this ends our part 1 webinar, and you can always join us on Thursday to hear from 4 other teams and the work that they were able to accomplish. But thank you so much for joining us today. And again, thank you so much to our presenters for their phenomenal work. And I am just so excited for everything that has been done and to share your report soon. So thank you and have a great day.
Thank you, Alison.
Thank you. Bye-bye.
Thank you, Alison. Bye, everyone.
Bye-bye. Bye.